appliance to treat sleep disorders breathing, presented by Steve Carsonson. If you guys have any questions, please feel free to ask them, and I will go ahead and turn the time over to you, Steve.
Okay, well, thank you for attending today's webinar. I've been asked to talk about oral appliances because some of you may not be as familiar with what dentists can do to be part of the treatment team here. And I have some expertise in working with oral appliances, and so they asked me to come talk to you, and I'm really happy to do that. Let's look at what we're going to talk about today. We're going to talk about how oral appliances work to manage the airway while people are asleep. That's, of course, what we're all after in sleep disorder breathing therapy. And what we can do with an oral appliance depends on many different factors, including the design of the oral appliance. So we'll talk about that a little bit. And there's several appliances that we'll talk about design features. We're not going to talk about all of them because we don't have that kind of time, but I will be able to give you some common design features and categories so you'll have some increased awareness of what's available to your patients as they come into therapy or as you consider sending them for oral appliance therapy going forward to help them manage their airway. We'll also talk about what the literature says about CPAP and oral appliances. There's quite a bit of this literature now. I've got a few papers that I'll be telling you about that compare directly oral appliance therapy versus CPAP. Or not really versus CPAP, but compared to CPAP. Because I don't really consider oral appliances versus CPAP. It's not really one or the other. In my practice, and I think in most dentist practices, if we could get everybody to use a CPAP, it would be excellent because we know that CPAP works really well. But we also know that CPAP adherence is somewhat challenging. And oral appliance therapy is something that can be used to help those patients who, even if they really do benefit best with CPAP therapy, oral appliances are something that can be very effective, as much as CPAP in all ranges of patient care, or at least more effective than zero. And the patients who should be using a CPAP, but that CPAP is collecting dust in a corner, nobody wins on that circumstance because we've done a diagnosis, we've done a prescribed therapy, they're not doing that therapy, and so their chief complaints, whatever's going on with them, is not getting fixed. And if it's something simple as, my bed partner is unhappy because I snore, well, that's one level of concern. But we all know that some of those patients have some pretty significant medical issues, and we don't want them to be untreated. If we can add in then an effective therapy, oral appliances, and help them get treated, well, yay. What if we add in oral appliances and it's not quite as effective as CPAP, but yet it's still being used? Well, that's an excellent, I think, clinical direction to take. And who knows what happens when they get a little glimpse of good therapy. Maybe that'll get them to bring that CPAP back out of the closet and get what the most effective therapy. Or maybe the oral appliances will be completely effective. The interesting part about this is no matter who you talk to, no matter what literature you read, there's a mixture of results. Some of the studies are showing that oral appliances can be just as effective as CPAP all along the treatment spectrum. Most of them show, and we'll talk about this later, most of them show that it's really, really great for mild sleep apnea patients. But we'll talk about how we can approach our patients with that kind of therapy. But overall, the goal is to make sure that oral appliance therapy is on the table as a potential treatment for any patient that you see so that you can have the full range of options to discuss that with your patients. When a patient has an oral appliance, what we're trying to do is get the airway to stay open. Now with CPAP therapy, with any kind of PAP therapy, whether it be a BiPAP or any of those others, then the air pressure is changed to balloon up the tissues behind the tongue to make sure that airway stays open and the normal functions happen. They can breathe back and forth through that open airway. Oral appliances work a different way, and we'll talk about how they work as they bring that airway open through bringing the pharyngeal tissues forward. But we don't know how far forward the jaw has to go to get the airway to stay open. Nobody can test for that yet, although there's something we'll talk about coming up that we may be able to do some more of that. But right now, what we have is we have people getting oral appliances with not really a clear target for where their jaw has to go to get that airway to stay open. So we call that calibrating the airway. And as we calibrate the airway with the oral appliance, we can do that in a few different ways. And we'll talk about how we do that and what the therapist's role can play in that, what the physician's role can play, and I'll tell you and describe for you what the dentists do to calibrate the airway with the oral appliance. And then the other big thing that happens is when you have patients sitting there that you would love to send to the dentist to get an oral appliance, how do you know, first of all, how do you find a dentist that knows what's going on about this, and how do you differentiate that dentist versus another dentist? Or what if you get, a number of dentists approaching you to say, please send me your patients who you would like to have an oral appliance therapy. I'm happy to make those for you. What kind of criteria can you use to talk about which dentists are worthy of your referral? In other words, and then when I say that, I really mean which ones are most likely to be successful in not only helping that patient with the airway calibration on the bottom line, but also be a good partner with you. It doesn't do anybody any good if you send somebody to a dentist and they make an appliance and then you never see that patient again, because how do you know it's working? You've got responsibility for their medical issues, and yet you need to be partners with that. It's not good for the dentist if they don't send them back for that reevaluation. It's not good for the patient if the patient doesn't feel like it's a team effort to get things working for that patient. So these are the things we're going to talk about today. So let's begin with, how do oral appliances work? Well, naturally, what we're after is keeping the pharyngeal tissue airway open. So if we're talking about the tissues that are down here behind the base of the tongue, in the airway, trying to get that move forward, the bottom line basics of all of the oral appliances out there are we take the lower jaw and we move it forward. And as we move it forward here, then the pieces back here are stretched forward and we keep that airway open. So that's it. That's really the summary of the whole thing. And there's 90 different appliances out there that do basically that. If we could stop there, it'd be great. But up to dentists, there's some customizations here, and there's a lot of complexity, as we all know, in this anatomy. And so we have to be able to apply what we know to that complexity. We have cephalometric X-rays, images of the side of the head that show us things like the airway. So let's look at that. And we write in landmarks, and we measure this for braces purposes. We measure this when we're thinking about doing jaw surgery. We measure this for things, even sinus surgeries. We measure the positions of the relative parts here. On this picture, we have a dimension that we look at from the back of the mandible. We call it the angle of the mandible here, to the front side of the posterior pharyngeal wall, and we have a dimension that we can measure. This patient is postured with a device between the teeth, the upper and lower teeth, made out of plastic, so it doesn't show up very well on this image. But this device that we use, you'll see it later on in some photos, is used to posture the mandible in 3 dimensions to discover not only how far they can move their jaw, but also where do we begin our therapy. The next image we have here shows it with the mandible protruded. So if we look back at that previous image, look at the relationship of this tooth to this tooth here, and when we protrude the mandible, now we have this relationship has moved forward. So the jaw has been pushed forward, and now look at this. That same space that we measured before is now much bigger. So the amount of the dimension we have of the airway back here now is much larger. This is a great thing. Wouldn't it be fantastic if we could use something as simple as a lateral head film to discover who would respond well to a protruded mandible and open their airway space? Unfortunately, well, fortunately, I suppose, we breathe through a 3-dimensional space. This X-ray obviously is 2-dimensional, and on this particular view, we see a much larger airway space. But let's look at things like this in 3 dimensions. These days, with MRIs and cone beam CTs and CAT scans, what we can do is we can visualize body parts in 3 dimensions. So this image here is a reconstruction from a MRI, and what we have is we're standing on the posterior pharyngeal wall and we're looking forward at the inside of the mandible. The blue part here is the airway. The red part is some surrounding tissues. So what we have here is, with no oral appliance in place, we have a certain dimension in light blue of the airway space. With the oral appliance in place, and so the mandible is now protruded, just like in a second head film, what we see is that blue area is expanded. Notice it's wider here. Well, this is wider in lateral view. So let's look at this from down from the top, and you'll see the same kind of thing. There's our mandible, there's the tongue base here, and there's our airway back here. The lumen is in light blue, and the kind of the whole airway space, oral pharynx, is in dark blue. And without the oral appliance in place, it carries a certain amount of space here, volume, really in 3 dimensions, that we breathe through. Now we've moved the jaw forward, and look what happened here. The lumen space didn't really get much bigger. So this area here is not much bigger than the area on the top without the jaw coming forward. But there's that wider in the dimension lateral, it got bigger. Well, imagine if we were taking a head film, that cephalometric x-ray we just saw, takes a 2-dimensional picture from the side. Well, from the side, this airway would not look any bigger than the top airway does, because that didn't change in an AP view. It changed in a lateral dimension. So unfortunately, our cephalometric x-rays, simple to take, inexpensive, low radiation exposure, are not good enough to show the differences between potential responders and potential non-responders to mandibular protrusion with an oral appliance. We know from this study that produced these images, and other studies very similar, this has been replicated many times, is that the biggest dimensional change is not AP, it's lateral. So the amount of distance that a patient can move their lower jaw forward is also a non-predictor of the ability of the airway to change shape with a mandibular protrusion. Now, we do have to have a certain amount of protrusion available, and we'll talk about that when we get to the appliance section. But what we have here is a graphic description of what some of this protrusion does, and that is it stretches these tissues. Now, we think this is happening, and this is poorly understood actually. We think this is happening because we can envision something that attaches the lateral oral pharyngeal walls to the mandible. And of course, this is also in 3 dimensions and, all up and down and everything. So this little scribble here is not descriptive of what's going on, but you can kind of visualize that as the jaw comes forward, something is attached here and drawing that forward. And as it comes forward that way, that stretches the shape here, and that ends up opening that airway. How that might be applicable is that we know that people's body shapes have little to do with whether they'll respond to either CPAP therapy or oral appliances. There seems to be some genetic component to the contribution of their airway space to sleep disorder breathing. This may be where it comes in, just in the details of how the airway shape is, how it responds when the jaw comes forward, the direction of force applied to the airway shape and the walls of that airway shape, and the relative elasticity of that. All these things can be controlled or really, I guess, ascribed to genetics. Why it runs in families may be connected here. Bottom line is we can't use imaging at this point to predict responders versus non-responders. So when people come in and talk to you and they say, well, am I a good candidate for oral appliance therapy? Unfortunately, you can't say, well, let's take an x-ray and find out. Bottom line, we bring the jaw forward, opens the airway. We don't know how it works precisely, and even when we think we know how it works in one person, we can't really say it works that way in somebody else because of the things we were just talking about, but this is what it shows. So one of the questions is does it increase the muscle tone of the oral pharynx? Dr. Isono did the iconic work for bringing the pharynx open by mandibular protrusion. I think I've seen these pictures in almost every basic OSA, sleep disorder breathing, oral appliance therapy lectures that I've seen because they are really just the fundamentals of our profession here. So I know these are probably familiar to you, but just to go over it again, what they did is they put a patient to sleep with propofol, so they mimicked sleep, and when they did that, they instituted a nasopharyngeal seal, and then they pumped it up with air pressure, and the air pressure ranges here from 20 centimeters on the top end down to 0, or one centimeter, I guess, of water here on the bottom. And they studied what the airway looked like at different pressures. And you can follow along here from 20 centimeters of water down all the way to 4 here, where it's still open at 4, but it's kind of closed at 2 and then it's closed at 1. Interestingly, this is also the baseline study for why CPAP machines run from 4 centimeters up to 20, because they know that if they go lower than 4, it's sham or it's not really effective. So then they brought the jaw forward and they studied, well, what happens with the same pressure variance over a protruded mandible? And notice that 20 centimeters is still about the same. It looks pretty similar to the 20 centimeters of water pressure here with the mandible protruded. And then you follow down this along, and then you start to notice that at 10 centimeters, 8 centimeters, 6 centimeters, that the airway is closing down with the pressure here, but not with the mandible protruded at that same pressure. 4 centimeters, kind of a dramatic difference. With the mandible protruded, we have quite a much bigger lumen than we did with 4 centimeters of pressure with no protrusion. And with the protruded mandible staying open all the way down to really, 1 atmosphere of pressure, then we have a effective opening of the airway with protrusion alone. And it's not more open with pressure. So that is this baseline for why we think about bringing the jaw forward to open the airway. Here's a graphic description of that. And the bottom curve here is the pressure alone. The upper curve is with the oral appliance in place. And so they brought the jaw forward, nasopharynx, oral pharynx here. And as you can see here, from 0 pressure of water all the way up, we track the same here, opening, but it starts at a higher area here, or area of cross-sectional area of the airway being open with the mandibular protrusion. So does this work because it just mechanically pulls things forward, or does it work because the pharyngeal muscles are more active? They studied this too. And what they studied here is we have airflow, so they measured airflow, and notice there's limitations to the airflow. It kind of closes off here and here. And they studied the pressure in the esophagus, in the airway. Sorry, they studied the pressure in the airway in centimeters of water, and when the air is trying to flow but can't, then the pressure drops because the chest is still expanding. There can't be any airflow. And so the vacuum is pulled there in the esophageal airway. What happens then? The body's trying to get this open, so the genioglossus muscle was, an EMG was put in the genioglossus muscle, and I tracked that along, and notice what happens. No airflow, body's trying to flow air, so it's pulling a negative pressure here, and the genioglossus is quite active at that time, so it's trying to pull that tongue base forward to open up the airway. And so we see this tracking in temporal time here, here, there, here, all along. So no airflow, negative pressure, active genioglossus. So then they did it with the jaw forward. And look at this. Now we have airflow is a better pattern, but there's still some flow limitations happening here and here. And so that results in some negative pressures, just like on the previous screen, although less negative pressure and more airflow. But look what happened to the genioglossus muscle. With the airway staying open most of the time and much less negative pressure, the genioglossus didn't work. So bringing the jaw forward did not produce increased pharyngeal dilator muscle activity. It actually decreased pharyngeal dilator muscle activity. Now, there's 50 muscles that control the shape of the pharynx, and they've only studied 2 of them with EMGs, including the genioglossus, because it's very accessible. So we don't really know what happens to all those other muscles, but we presume from some things like this that there's not a lot of extra muscle, dilator muscle activity happening just because we bring the jaw forward. So it's a passive thing, that's what it is, really. And it kind of works for us, because when is the worst sleep? It's in REM sleep. What's happening in REM sleep? Most of the muscles go passive, and so if we were depending on increased dilator muscle activity, we'd be in trouble for that, because during REM sleep we'd have passive muscle activity. So it's much better to have it just mechanically, which is kind of like CPAP. CPAP does that with air pressure. We do it with oral appliances by just simply posturing forward. So the mandibular protrusion opens that pharynx by stretching soft tissues, including muscles, ligaments, all those other parts, attached to the pharyngeal wall, not really by activating those dilating muscles. Now, there's a limitation, however. All of us sitting here, we can push our jaws forward, and we have a certain limitation to that voluntary forward posture. We can only command our jaws to come forward a certain amount. I can tell you that we can passively stretch it forward a little bit more if we have an active device doing that. But if we think about just the limit that we have of being able to move the jaw forward, it's limited by ligaments and stretchy tissues and muscles and just the general shape of the temporomandibular joints and the parts associated with them. What I explain to my patients all the time is that I'm going to measure how far forward and back that they can move the jaw. As we get a certain range that they can work within. That may not be the limitation to how far they can move their jaw. It is that day. As they begin to wear oral appliances, and the goal is to open that airway, and so we stretch that jaw forward, it could be that they're within their range of motion is the sweet spot where everything stays open. It could be that it doesn't currently reside within that range, and what we need to do is increase the range. Well, think about this. If you go and take an exercise class, and the one I use with my patients all the time is yoga, and I go take my first yoga class, and the instructor has me bending over and touching my toes, well, that's either a difficult, impossible, or a challenge for me to make happen. If I continue with that yoga class, though, and do that repeatedly, certainly I'm going to be better at that later on, as my body is able to adapt to this new challenge and respond with more flexibility or whatever is required to make that happen. So we can assure our patients that if they can't bring their jaw forward far enough to open that airway the first night or 2 or month, then that's okay. They can work up to it. So all of our appliances are adjustable, and we'll talk about that coming up, but that's why they're adjustable, is because we don't know where their sweet spot is to get their airway open, and we don't know if they can even get there on the first night, even if we knew where that spot was. So the limitation around the jaw joint is only short term. As you see your patients come through and they say, oh, I'm not sure I could wear an oral appliance because I have had TMJ. Oh, I'm not sure I could wear that because my jaw doesn't move very far. I have not yet met a patient who I haven't been willing to put an oral appliance in. In fact, we treat TMJ issues with oral appliance therapy nowadays, so we don't consider that much of a limitation. Now, it's true that there are a few people out there with very significant damage and disability to their jaw joints. They have bigger problems, and then certainly those are limitations, but that is by far the rarity out there. So do not let limitations in TMJ issues deter you from referring that patient that you suspect might benefit from an oral appliance therapy for a consult. Here's an interesting observation that they made also. We know for some reason, we know that oral appliance therapy is not as effective in the most obese patients as it is in people of more normal weight. The more obese they are, the less predictable oral appliance therapy is. One of the things that they discovered as they did some of these studies is they discovered that the effect of protruding the mandible on the velopharynx was diminished. So normally what we see with a normal weight person, we bring the jaw forward and we have a good effect on these tissues back here, and we end up opening this space. We actually tug on the palate so the palate comes down a little bit. The more obese patient tends to have less effect on the palate and this space doesn't open up. And so to the most obese patients, I tell them that they may end up having to breathe through their mouth a little bit more because of the velopharynx, or their palate not opening up on the back of their throat. It also, that affects which appliance I might choose, because I want to make sure that they're going to have one that they can breathe through their mouth if they need to. And everybody understands that we want their patients breathing through their nose, but you know what? Sometimes we have to make compromises, and so the more obese patient we have, the more likely they are to breathe through their mouth. So let's talk about oral appliance therapy for a little bit. History, they've come a long ways. In the early 1900s, there was reports in the literature about infants who couldn't breathe well, and they would take that tongue with these are patients with a poorly developed lower jaw, and they'd actually suture the tongue forward just so they can keep the airway open. And then they did bizarre things like having these helmets, chin straps. In the early 30s, Pierre Robin, French physician, came around and published the first reports of using something to posture the mandible forward to help with the airway staying open. So the American Academy of Dental Sleep Medicine, as a matter of fact, considers Pierre Robin to be one of the founders of airway management using oral appliances. Hooray. Well, that was in 1934. Then we jump forward 40, almost 50 years before it really became an important part of therapy. I don't really know what happened during all that time, but they were discovering things like REM sleep and EEGs. And in 1978, they came up with an airway pressure called CPAP, that they were able to now start to open up the airway from external forces. Before that, all they had was tracheostomies. So when I was in dental school, I graduated in 83. So in 79, I was starting dental school, and look at this. In 79 is when the first time they came around to be looking at using the mandible to use the mandible advancement to open the airway right here. In 82, they reported on a tongue retaining device. We'll talk about that coming up here in a minute. And in the starting in the 80s, then, because they were starting to become common, authors started to write up papers using oral appliance therapy as an adjunct to the pressure devices that were being developed, kind of all at the same time. The first patent on mandibular advancement device was in 87. Actually, a dentist was taking a course in CPR therapy. And back in those days, for CPR, the very first thing we ever did was to use a jaw thrust procedure to open the airway. He got to thinking about patients who were snoring and said, what if we used a couple of different mouth guards and we glued them together and mimicked that jaw thrust position? What would that do? And sure enough, their snoring went away. And that was the first mandibular advancement device thought of to use for sleep and breathing, first just in snoring. So since then, many papers have been published, and it culminates here in the 2000s. So here we are, less than 10 years away from placebo-controlled data. In 2005, the American Academy of Sleep Medicine, the folks who write these kind of things, wrote a very important practice parameters paper that included oral appliance therapy as first-line treatment for mild forms of sleep disorder breathing, and to be considered for every patient who couldn't use the other options that are available, like CPAP. So oral appliance therapy are codified in practice parameters papers in 2005. That's up for review now, and we're going to have probably an even increased role playing going forward. So let's look at oral appliances and their types. A lot of different kinds of oral appliances out there. I'm going to cover a couple of different categories of those so that you can see, get a little bit of understanding of what you might be seeing as your patients come through, what they, being able to kind of discuss with them a little bit about how they work, excuse me, how they work when you're sending them out over to be considered by a dentist for effectiveness here. The first ones are tongue retaining devices. Now, as kids, we all did this. What did? We took a soda bottle and we kind of sucked the vacuum in the soda bottle, stuck their tongue in the soda bottle, and we held the soda bottle up by our tongue. At least, maybe I'm the only one that did that, but I did it a lot. Well, that is a tongue retaining device. And in modern days, what we do with patients is we have them in, and most of them are not this custom type of device where we take a model of the teeth, but they're actually something much simpler. And they come in small, medium, and large, and we match them up to the size of the tongue. And by the way, the reason they're not custom is because how do you take an impression of a tongue? It's kind of, you can actually do it, but it's hard. So, but we have small, medium, and large. And what happens is they go in the mouth, and the bulb out here is squeezed, the tongue is pushed into here, and then as the tongue bulb is released, vacuum holds the tip of the tongue forward in the tongue retaining device. And they can kind of slip in and out of the mouth. This one fits over the teeth. This goes in front of the teeth, underneath the lip. This one over here is a little longer, so it goes out there. But most importantly to realize is this is the only oral appliance we've got for edentulous patients, people with no teeth at all. We do have a couple that can work when the upper teeth are missing, but we don't have any appliances that work well over somebody with no lower teeth. So we use tongue retaining devices for that. When we do that, we can also use them for patients who are skeptical about the value of oral appliance therapy, because we can give them one of these. It doesn't cost very much. We can give them when they go home with it, they try it out. When they try it out, they realize that they're breathing better, but they don't like the way this feels, because when you put your tongue into a vacuum like this, it makes the tip of your tongue very sore. And functioning on a daily basis with a very sore tip of your tongue is not a comfortable place. So I've never had a patient yet, and most of my colleagues tell me that their tongue retaining device patients are not using their devices very well. So the adherence to therapy is very poor with tongue retaining devices, which kind of makes them not useful in the marketplace. If they do get a glimpse into a preferred future, in other words, they're treated pretty well, but they don't like the tongue retaining device, that might help them see the value in working their way through the issues they had with CPAP, however. So we give them a chance to feel what they can feel as with a well-treated situation, and then they go back to CPAP and they, kind of make it work because they're more motivated once they've glimpsed that. So that's probably one of the biggest features that we can use tongue retaining devices for, especially with our edentulous patients. Now here's one. This is a variation. It happens to have some little airway tubes attached to it right here, because if we have a patient who, say, can't breathe through their nose very well, and we give them a tongue retaining device, well, that opens up the oral pharynx, but it also kind of seals the mouth up. And giving the patient a sealed up mouth with poor nasal breathing, now we're not helping them any. So this design was added with the airways. This is not founded in good science. It's just something somebody tried, which kind of illustrates what happens in oral appliance therapy, and it doesn't work any better than ones without the airway, it turns out. So let's talk about these. These are more common. This is the thing that's been researched. Kind of substitute names, mandibular repositioning devices. Well, true, but repositioning doesn't work unless you advance, so the more descriptive term is actually mandibular advancement devices. MADS is used, oral appliance therapy, all kinds of acronyms. Nobody's settled on this on one. Probably the most descriptive is mandibular advancement devices, so they all do that. Mandibular stabilization devices would be another good choice. So let's look at some variations. Method of retention is most important. When we have the lower jaw coming forward, it's trying to return to its normal position with some stretchy tissues, those ligaments and things that I mentioned about the jaw joint. So the teeth are used to anchor the lower jaw going forward. In other words, they're hanging onto the teeth so the jaw doesn't fall backwards. That comes in a number of different ways, and different manufacturers use different materials, but we do have to have enough teeth to serve as good retentive. The question is always how many teeth do we need? It doesn't really matter how many teeth we have, it matters how strong they are. Somebody with 2 really great teeth, we can use a mandibular advancement device on. Now, we're a little riskier with that, and we have a different conversation with our patients when we have fewer teeth, but it doesn't mean we can't do it. Implants work really well. A few teeth, we certainly have to have some teeth on the lower arch. More teeth is better. That kind of makes sense. The materials can come in a very flexible manner, so they heat up, they go over the teeth. They can be very rigid, so the different designs are varying on how they feel in the mouth. And some patients, some dentists are more used to different levels of flexibility. So they might like an appliance that bends around quite a bit, and other people might like ones that are very solid and strong. Most of the appliances that are effective are adjustable. There are some fixed position devices that have tested well, but the key is how do you know which position they're in? Sometimes I make fixed position devices once we've proven that the appliance is working in the position we've adjusted it to, then we can convert it to a fixed position device because they can be a little smaller or simpler. But we never start with a fixed position device because we never know really where anybody needs to go. Vertical opening is interesting as we think about how far open the jaw comes, not just how far it goes forward and back. I showed you images of changes in the tissue space, the tissue surrounding the space with mandibular protrusion. There hasn't been similar studies of changes in vertical dimension and the effect on that airway space. We don't have any science behind that. So dentists vary vertical opening as a response to patient outcomes. If they're responding well, we don't mess with it. If we're doing everything we can and they're not responding well to the oral appliance, mandibular advancement device, then we change the vertical to see what happens. But we don't have any good way to test for that yet either. Certainly this is a big factor because the appliances widely vary on how much the jaw can move. Some patients want a lot of jaw movement or else they're going to feel bad and not use the appliance. Other patients really would much prefer their appliance to fix their jaw in place because they really don't want to have to worry about their jaw falling open and mouth breathing. So we have different characteristics of the different appliances so that we can do different things. Whether we make them in our lab or we make them in the office, that's a difference between appliances. We'll talk about some the office constructed appliances here coming up. And then mostly the dentists get comfortable. I tell dentists all the time that they need to be very adept at 3 or 4 appliances. They need to be masters of 3 or 4 appliances, and then there's about 90 others that they probably don't need to spend much time with because they'll be able to solve most patient concerns with the ones that they're masters at and the ones that they're adept at. A lot of different designs here. This is just a smattering of them. We'll talk about a few of these coming forward, but there's tons of different ones out there, so you'll probably never be surprised at what you see the patients presenting when they come back for follow-up, but you'll start to see a pattern because there's a few out there that seem to have a bigger market share. Let's talk about this one. Now, I'm not endorsing this appliance. I think it's a great appliance by chance, but I just wanted to use this as an example to kind of show you what they do. Certain of these characteristics are common amongst many appliances, and so let's do that. And what we have here is we take a mold of the patient's teeth, and so we have something custom made. It's much like a night guard or something that might be more familiar. It's either vacuum made or it's press fitted or it's made out of regular acrylic, or now we have a new one that has this CAD cam. It's made custom to fit the patient's teeth. In this particular design, the adjustment mechanism is in front. We'll look at that coming up. So in the mouth, this one looks like this. We have this custom fitted over the top teeth. We have it custom fitted over the bottom teeth. This design has a hook mechanism in the front. The patient protrudes their jaw and slides the lower piece around the hook and engages it. And so now we have this posture here where the lower jaw's forward. And so if you look closely at this picture, here's the plane of the lower front teeth and the upper front teeth are back here. You know that when people bite down, typically the lower front the lower teeth are behind the upper teeth. And so if we have this in the mouth and they bite down, this is what it looks like to go further forward with this particular device. This one is adjustable, and you adjust this one by changing the position of the hook in this scale. You put a key here in the front, and as you turn that, there's a screw inside there that brings this adjustment device further forward. So we can bring the jaw further forward with it. This is a continuous screw, so the patient can adjust that at any rate that they want. I tell patients if they go too fast, all they can do is kind of hurt themselves, but they can't damage anything. And so as we go forward with this, they get to dial that in to allow their jaws to become more flexible at the rate that their jaws become more flexible. So we don't mandate that they jump from one place to another. We just simply allow their jaw to come forward at the rate that they can do. So here's another showing of this. Now, this particular device has an advantage, and we'll show you that later on, for you therapists interested in calibrating the airway during a sleep study. How do we know where to start? We start with a three-dimensional view of where the patient goes, and this is called a George gauge, and it's named after Dr. Peter George, who invented it. And what it ends up doing, and I'll show it to you in the mouth, we posture the jaw forward. We measure how far forward they can go. Sorry, let's go back to this. We measure with this little scale over here how far forward and back they can protrude their jaw. We make some determination about where on that continual scale we're going to begin. We lock it down with these set screws, and then we put it back in the mouth with some registration material, and we end up getting a three-dimensional view of where the patient's going to begin. We do get an opportunity to ask them at that point, how's that feel? So they can tell us whether that's a good place to start. Now, because if it hurts, we're not going to start there. And because we know our appliances are adjustable, we can take all those factors into account. We end up with a good place to start. There is a little science behind where we choose to start, not very much. And so we do have some arbitrariness in how we begin the start position, but that's how we do it. So the FDA says these are Class 2 medical devices. They have to be made in laboratories that are certified. And interestingly, out of the 90 or so on the market, there's been very few that have been cleared as Class 2 medical devices by solid research. The vast majority are cleared by what's called 510 clearance, which basically means that they say that, gosh, that other appliance moves the jaw forward and opens the airway, and mine moves the jaw forward, so it must open the airway too. So mine's like that one, so I should get clearance to market it, and that's what happens. So when your appliance manufacturers say that, gosh, mine's well surrounded by science, you got to make sure that that's true. FDA clearance is not just is only for marketing purposes. It's not necessarily mean that they're well founded by science. So let's look at what the science says. And there's a whole lot of papers out there. You can go to PubMed and do a search on oral appliances, and there's a lot of papers. But I picked a few, and Dr. Lettieri here did one of the biggest studies out there now. And this study was done recently. This was published in 2011 in Chest, so obviously a good journal. And what he studied 497 patients in this, and they compared oral appliances against CPAP for mild sleep apnea. And what they found is that oral appliances and CPAP were completely equivalent for mild sleep apnea across their population of 497 patients. Now, they had a captured population because they were studying servicemen and women. And because they're servicemen and women, compliance with therapy and adherence and repeats polysomnography was not a limitation. The only time they couldn't follow up was when that service member got deployed, for example. But they did find, and they duplicated other studies that showed that CPAP is more effective for moderate and severe sleep apnea. We know that. We've known that from other studies. And now over 497 patients, Dr. Lettieri and his group duplicated that. But for mild sleep apnea, they're comparable. And just like every other study, out of those people, they really liked using the oral appliance better. So here's another one. And Dr. Lobizo and Dr. Arab, they published quite a few things. This is in the Journal of Respiration. And they found no significant difference between oral appliance and CPAP for mild or moderate sleep apnea when they're titrated in the laboratory. So this is important because what they did here is they looked at these are patients with oral appliances. This is the whole range of AHI here, and they brought them down under 10 for most of those patients except for a couple. And then what they showed in the big study is they took these patients here that didn't respond, notice where they started in more severe categories, and they titrated in the laboratory, and both of those patients became responders when they got them in the laboratory and adjusted the appliance further forward. CPAP predictably got everybody treated, and these are the same patients, 47 patients in this study, and everybody became fully treated with CPAP because they can titrate that in the laboratory. And over here, they did a sham treatments with these patients and with oral appliances. And notice this person here got much worse with an oral appliance, and we see a few others like that. And so we have to be very careful as dentists making appliances that are not protruding the mandible. What about temporary appliances? Well, it would be great if we had a temporary appliance, and this is actually one that I use in my office, and we can take a tray and we can fill it with some rigid material and make it work a little bit. And what doesn't show here is there's an upper and lower tray, and we can slide it back and forth. But the temporary appliances, Dr. Vanderbeek, and this is his summary from a study published in 2008, and what he says here is that the thermoplastic devices, the boil and bite devices, don't give us a very good test. And the danger we have with using something like this is if a patient uses a boil and bite and says it doesn't work because it's uncomfortable or it's too big or something like this, they might think that that's true for the custom devices as well. And that's not true. That's been validated by science that a trial appliance using thermoplastics isn't really a very good trial. So unfortunately, we don't have a great trial device to make sure that we know this thing's going to work. There's another study that they did that shows that titrated oral appliances, and what they mean by that is the patient is in the laboratory with their oral appliance in place, and the technician is watching that study just like they do with a trial of a PAP, and when it's not effective enough, they go through and they adjust the oral appliance until they calibrate that airway big enough. Very effective to reduce AHI and certainly a higher reported compliance. And that's been true over and over and over again, that patients prefer oral appliances. Now, interestingly on this study also, one-night titrations of oral appliances had a low negative predictive value. So in other words, if they got the oral appliance in there on their very first night and they couldn't make that airway stay open on a comfortable basis for the patients, that really is a low negative predictive value. So it didn't really predict non-responders. It wasn't very valuable for finding out whether anybody couldn't respond. Back to that flexibility issue, because we know that people can become more flexible over time. They could turn into responders if they gave it enough of a go at it. Much like people, if they power through it, they can get accommodated to CPAP. So really in behavioral medicine, it's a lot about how much effort people put into it. And that's true for oral appliances as well. So how do you calibrate the airway during a sleep test? Well, you have to know how the appliance is adjusted. Now, the one I showed you earlier happens to be a tap appliance, and I don't mean to be a name brand person here. This is just the one that has the key in the front here. And it can be adjusted. The only appliance that can be adjusted while in the mouth by the technician with the patient asleep, because all you have to do is reach into that little attachment there with that key and turn it while the patient's sleeping. So that's the only one you can do that to. It's pretty great for that. It's also, but you also have to have a trained technician and you have to have a willing patient to let that happen. And it happens quite a bit in many labs around the country. Now there's something called bilaterals. I'll show you pictures of that, so don't be confused about the term. But the tap and the clearway is another category of these. You have to take the appliance out of the mouth, and there's various ways of adjusting these, so the technician has to be quite adept at that. But really what the practical reality is if you're going to calibrate the airway during a sleep test, you're involving the patient. the patient's going to take the appliance out, going to make the adjustments, and put it back in and go back to sleep. So you can imagine that by itself is disruptive, and so you're not going to get a night's sleep in the laboratory that's not disrupted. You're going to get one that has lots of interruptions, but some interspersed with periods of trials of jaw position. So here's one that this is the tap. This is adjusted in front. I showed you this earlier. This happened, a new design of that, but there's that key slot, so it goes in front. Here's another one called a silencer, very similar to that one. These are the bilaterals. And so here's a very popular one. This one's actually made by one of the laboratories, by Gergen's Orthodontic Laboratory. And this one is adjusted by this little screw right through here. So you turn a barrel right here, and that makes the jaw come forward. This one has a nylon straps that are changed. This one has a little screw in the middle of it here that you crank with a crank, and that same screw is right there. On a Somnomid, another very popular device you might see, has little wings on the side to keep the jaw from falling backwards. This EMA is a very popular device because it's kind of inexpensive. Changes with these nylon straps, much like the nylon straps on the one on the bottom. So the knowing what your patient has in the mouth and enlisting their help in how to make adjustments will prepare you for calibrating that airway on a bilateral adjustment device. Here's the clear way, and it's a kind of a unique one because of the adjustment here. There's that same screw as on those other two appliances, but this one's placed in the palate up above the tongue, and then it by changing that position, it changes the lower jaw by not advancing this one here too. You got to get it out of the mouth to make that change. Now, here's an interesting device. You haven't seen this one probably much yet. This is called Matrix. It's made by Zephyr Technologies, marketed by one of the companies, Somnomed. And what happens here is the patient comes to the dentist. These are semi-custom trays. We make something that makes a retainer over the teeth. They sleep with this. This box hangs out of their mouth. Now doesn't weigh but about 20 grams, so it's not a big deal. And it's hooked up to the technician's console. So just like we calibrate CPAP by changing pressures until the airway is open, this one we get to have in the mouth, and we move the lower jaw forward with this box from the console until the airway stays open. So this is an interesting new device. It's brand new on the market, and you might see some of that coming up, called Matrix. So how do you find a dentist? Probably the best way is to go to American Academy of Dental Sleep Medicine. Most dentists that do oral appliance therapy are members of this organization. And it represents, it's a trade organization for that. You can ask your dentist, go to your dental office at your next cleaning and say, by the way, I need to find a dentist that does this, and maybe they know who in town has been taking the training and kind of put themselves out as the sleep dentist. You can also Google that in your town. You can go to Gergen's Ortho, and one of the sponsors of this organization, and Gergen's Ortho has clients everywhere. And so you can find out from them, if you're in town, if they have a client that's in your town too, and then they're plugged in because they have some confidence in how they can do that. And there's a special category, I'm one of those, you saw that coming up earlier, that diplomates of the American Board of Dental Sleep Medicine. And those are dentists, there's a few of us, I think there's about 200 of us, and what we've done is we've fairly declared that we are interested in doing this and passed the test and established that we know what we're doing and so on and so forth. But mostly we're serious about it. So those are the people that you can tell are going to be into this as collaborators, not just as people who can make oral appliances. Because you want somebody who's interested in the medical aspects of this to form a good team with you and end up with a patient with the best results. The goal is not to get them an appliance, the goal is to get them the best results. So those are some sources for finding a dentist in your town. So in summary now, what happens here? The oral appliances move the lower jaw. They bring it forward. They stretch the tissues behind the tongue. They keep that airway open. They're comparable to CPAP for all mild sleep apnea patients. They're comparable to CPAP for many moderate and severe patients, and they're way better than no treatment, which is true for an unfortunately large number of PAP prescribed patients. So the goal here is to get people treated, and any treatment that is used is better than any treatment that's not used. There's a lot of different designs. Physicians and therapists do not have to become experts at design, but it's kind of cool if they know a little bit about that. So I've given you some basics on designs. They can be adjusted during a sleep test to calibrate the airway, different ways of doing that. And there are dentists in your community, no doubt, who are interested in becoming partners with helping your patients get better. So thanks for watching. This is the first dental division webinar from the American Sleep and Breathing Academy. I'm very excited to be part of that. We do have a meeting coming up. Our very first meeting is going to be in Scottsdale Memorial Day weekend. So if you're interested in coming down and hearing what the most recent practical, clinical, and research-based information there is about dental interventions for sleep and breathing, that's where you come. Other than that, thank you for your time. I appreciate you being here. My name is Steve Karstensen. I'm in Bellevue, Washington, and I am excited to be part of the educational aspects of this.
All right. Thank you so much. That was so good.
Thank you.
You did a really good job. It was very, very clear and very, very understandable.